So welcome everyone. I'm so happy to see familiar faces and new faces here today. When we first started talking about doing a program on osteoporosis, everyone kept saying, you have to get Dr. Catherine Deemer to do this program. She is the osteoporosis guru. So when we snagged Dr. Deemer as today's presenter, I knew the program was going to be golden. So let me tell you a little bit more about Dr. Deemer. She is a highly respected physician and a St. Louis native, so that means we may have to ask her where she went to high school. But she received her medical training at Washington University and has been a part of the Bone Health Program since 1989. She is a leading expert on osteoporosis nationally and has served in leadership roles in the International Society for Bone Densitometry. She lectures nationally and internationally on osteoporosis and bone densitometry and has been named in St. Louis Magazine as one of St. Louis's 100 best doctors every year since 2002. She sees patients in the Bone Health Program at Barnes Jewish West County Hospital. And without further ado, I am going to turn things over to the osteoporosis guru, Dr. Deemer.
Good morning, everybody. Thank you, Susan. It's good to see everybody. And I'm really happy to do this. Yesterday in clinic, I had patients that I'd seen the year before, made recommendations for treatment, and they went home and they didn't do it because they went online, they talked to their friends, and they decided, or they went to the health food store and decided those were better ways to go. And as I say to my trainees, I almost always have somebody working with me. The internet is not our friend when it comes to medical information. So what I want to be able to do is to talk about the importance of treatment, the safety of treatment, and just how we approach this and make decisions in terms of treating patients. And I have been doing this a long time. And when I first started, we didn't have effective treatments for osteoporosis. We had estrogen and we had some old medications. One was called calcitonin. And what I had was a lot of ladies with fractures. Everybody knew when I had clinic because it was all these hunched up little old ladies. We've come a long way, and rarely now in patients that are being treated in our clinic do we even see fractures anymore. So first, we just have to talk about what osteoporosis is. It's a problem with bone strength, and that increases the risk of fractures. What's bone strength? Bone density is part of that. When we do bone density, we're measuring how much calcium is in the bones. Essentially, I would say how many bricks are in the building, but there's also other parts of this, the repair process of bone, the structure of bone. As you can see here, this is normal bone, and we call these the trabeculae. I refer to them as the girders of the building. And so if there's not enough bricks in the building, that doesn't help. But also if there's not a good infrastructure, that makes a difference as well. So how do we know these things? By doing bone density, which we'll talk about, and by looking at fractures. If patients have had a fracture, that tells me a lot about what's going on with their bones, even more than a bone density does. And that's essentially what we're seeing here, bone density, and then this whole issue of bone quality, which is the repair process. Age makes a difference in this as well. Falls are very important if somebody's falling a lot. So those are the kind of questions that we will ask. There are different types of fractures, and I think this is important as well. There are traumatic fractures, that anybody would have fractured with. And I'll just show a quick slide. This is me on my horse. And I have had fractures. Mine were all traumatic, but in some ways I feel kind of blessed that I was able to experience these. I've had a vertebral compression fracture. I've had pelvic fractures. I've had rib fractures. So it makes me understand what my patients are going through. And the hardest thing about osteoporosis, if just a bone density looks osteoporotic, is you don't feel anything until you have a fracture. And the best thing to do is to treat before that first fracture happens. There are pathologic fractures. There's something wrong with the bone. It can be cancer. It can be Paget's disease. So those are things that we look at. And there are stress fractures. And commonly I will have patients say, well, I've had this stress fracture in one foot and then the other. Those are not osteoporotic fractures. Those are due to different stresses. There are even something called cough fractures with the ribs, and people are coughing and coughing and coughing to the point where they stress out. Osteoporotic or fragility fractures are defined by a fracture that occurs with the force of a fall from a standing position or less. So I think that's important to understand, because sometimes I'll have patients say, well, I fell off the curb. Well, you're standing. you put your wrist out, that's an osteoporotic fracture, and it should be treated because we know once you've had one fracture, the risk of the next fracture doubles. So it's important to treat. There's me again on my horse. So the most common type of osteoporotic fracture are vertebral compression fractures. About 20% of the time, patients will present with pain and tell us they've had those, but many times we find them incidentally just on a chest x-ray. But those are important as well in terms of predicting fracture risk. We lose height with fractures. In the thoracic region especially, they fracture kind of in a wedge shape, and that's when we start seeing the kyphosis that occurs. Height loss, when I had my fracture 15 years ago now, I lost an inch in height. But the most common reason for height loss is not fractures, it's disc degeneration and arthritis. So, because I would say everybody tries to blame it on me, but it's usually not us that does it. Again, once you've had one fracture, the risk of the next fracture doubles. It predicts hip fractures, it predicts wrist fracture. Hip fractures, the second most common osteoporotic fracture. Most of the time they are caused by a fall. Only about 5% of the time does it happen spontaneously. I hear this all the time. Well, I was just standing there and it broke. Maybe that happens. 1% of falls leads to a hip fracture. Doesn't sound like much when you think of the millions of patients out there and the millions and millions of falls. That causes a lot of fractures. And I think this is very important because when I have patients who have low hip bone densities, they're like, oh, I'm kind of worried about these medications. The 1-year mortality, the 1-year risk of dying a year after having a fracture is close to 25%. It's worse than most cancer diagnoses. And I don't think patients understand that. Less than half of patients who have had a hip fracture return to normal, the life they had beforehand. Most will need some type of assistive device for walking, a cane or a walker, need help with their activities of daily living. And 20% of patients who have a hip fracture will be in a nursing home in a year. So I think even more importantly than being alive, it's being independent. And that's what we're after, is quality and quantity of life by preventing these fractures from happening, which we have very effective medications that can do that. Third most common osteoporotic fracture is the wrist fracture. They tend to occur in younger patients because if you look at kind of the dynamics, the way younger patients are moving, and they still have the reflexes to put their hand out to stop themselves from falling and get a wrist fracture, which is a lot better tolerated, I should say, than a hip fracture, although they can be troublesome as well. And in older patients, just because of a different center of gravity, tend to fall and break their hips. So what can we do to prevent that first fracture from happening? Well, bone density, dual X-ray absorptiometry, DEXA is what we call it. It's a very safe medication, very, very low radiation, 0.3 milligrams. To put that in perspective, chest X-ray has 30 milligrams. So you have to do 100 of these to get the same radiation exposure as a chest X-ray. They are accurate, and it's the best predictor we have for fractures in patients who haven't fractured. If they've had a fragility fracture, that's more important than what their bone density is. Because sometimes I have patients whose bone densities don't look too bad, but they've had a fragility fracture. Then they have osteoporosis, and that's the definition. When we do bone densities in postmenopausal women, men over 50, we use T-scores, which is comparing the patient's bone density to peak bone mass. -1 or better is normal. Between -1 and -2.5, we call it osteopenia or low bone mass. 2.5 or more negative is osteoporosis. And again, if you've had a fragility fracture, you have osteoporosis despite what the bone density says. We always do 2 sites. Usually it's a spine and hip. If we can't do a spine or hip, we do a wrist. We'll also do a wrist if patients have hyperparathyroidism, which is an abnormality of calcium balance with the parathyroid glands that affects the type of bone in the wrist more profoundly, and patients who are too big for the table. So, and the weight limits have gone up. We've got much stronger tables than we had when we first started. So rarely do we have to only do a wrist for that reason. And this is very important. The most common reason that I see new patients in clinic is they're being very appropriately treated by their primary care doctors and their bone density goes down. Number one reason is not anything the patients or the doctor did wrong. It's how the bone density was done. So this is just an example of this. So this is how a bone density should be positioned. You see this nice straight area, not a lot of what we call the lesser trochanter here. And that positioning is very important. So when we follow these patients, we don't follow the T-scores, a little science here. We follow what's called the grams per centimeter squared. And if I didn't look at this hip on the follow-up, said, wow, they're pretty close. That patient is stable. That's great. But when repositioning, as you can see here, appropriately, now we see a significant decrease in bone density. So what we do at our facility, which is not done much in St. Louis or anywhere, is something called precision testing, where our techs take 14 patients on and off the machine 3 times each. And then we see how close they are. And we know what a significant change is because there's some variation with positioning that can happen. So that's very important to know who's doing the bone density. And it should be on the same machine each time and same brand at least, because it's very hard to compare between different types of bone densitometry that is done. So be sure you're having this done. And I often have new patients say to me, wow, this was very different from what I have had done before, because your techs kept positioning and repositioning me, because we want to be accurate with this. And any patient that comes in to see me, we'll do a bone density in our machine, even if you already had one done. You'd be surprised how often we cure the person by doing the test correctly. So that's why I just don't trust anyone but our own machines. And we have very, very well-trained technologists, and we maintain our machines just perfectly. Bone density, again, is a very strong predictor of fracture. The lower your T-score, the more negative your T-score, the higher your risk of fractures is, but it's not perfect. Here you can see, this is about a -1. And here, this is a -2.5. So let's take the -2.5, the osteoporotic patient. The fracture risk is very different for a 50-year-old, 60-year-old, 70-year-old, 80-year-old. Just because of age, because of the change in the quality of bone as we get older. And you'll see, even an older patient with a fairly normal bone density has a higher risk than the 50 to 54-year-old does. So it's not just about bone density. I always say, I'm not treating a T-score, I'm treating a patient. We have to look at other risk factors to make those decisions. So there's something called the FRAX. The World Health Organization, a guy named John Canis in England came up with this algorithm where we look at patients' risk factors. So not just taking the bone density, looking at the whole patient. We look at age, we look at body mass index, and we'll start asking questions. Have you had a previous fracture? Yes or no? Has your parent had a hip fracture? Do you smoke? Are you on steroids? Rheumatoid arthritis? Alcohol more than 3 units per day? And then we put the bone density in. So what you can see with this patient is that her T-score in her hip was -2.1. But when we put in these other risk factors, the 10-year risk of a hip fracture is 6%, major osteoporotic fracture is 29%. This patient has osteoporosis, even though the bone density says it doesn't have it. This is not a perfect algorithm because we're only asking about family history of hip fractures. But we know 70% of our bone strength is from genetics. And if your parent has had multiple compression fractures, that should count. We just don't have the data for that. So we'll add things in and do what we need to do. And it's not quantifiable. It's current smoking. Somebody smoking a half pack per day has a very different fracture risk than somebody smoking 3 packs per day. So again, not perfect, but it can be very helpful to understand risk. The recommendation for treatment by the National Osteoporosis Foundation is to treat patients with fragility fractures, a T-score of -2.5, and using the FRAX, 10-year risk of a hip fracture of more than 3% or major osteoporotic fracture more than 20% meets criteria for osteoporosis and meets criteria for treatment. And some patients will say, but my T-score is this, I don't have osteoporosis. There's more to it than just that. And so I think that's very important to emphasize. So there's certain recommendations we have for all of our patients. And this is a common question that I get is how much calcium to take. The recommendations from the National Osteoporosis Foundation and the International Society of Osteoporosis is a total of 1,200 milligrams per day through diet and supplements if needed. And vitamin D, a baseline of 2,000 international units daily, but we measure vitamin D on every patient that comes in because vitamin D deficiency is so common that I have some patients who 400 units a day is all they need. I have other people who are on 10,000 a day, and we only can know that by treatment. The question also comes up, what's the best calcium to take? Calcium carbonate and calcium citrate are what has been studied. Calcium citrate seems to be better tolerated. And in patients who have to take Nexium or Prilosec, which takes the acid out of the stomach, calcium citrate is better absorbed than calcium carbonate. So I usually recommend calcium citrate, but either one is fine. If calcium carbonate is working for you, stay with that. Where we get in trouble with calcium supplements is is patients go to the health food stores. What you want to do when you get a supplement is make sure it says USP certified, United States Pharmacopoeia certified. So it really is calcium and it's really absorbed. You go to the health food store, you'll pay 10 times as much for calcium. And all it has to be is safe because it's considered a supplement, not held to the standard of a drug. Regular weight-bearing exercise, very important. Walking is perfect and a great thing to do because everybody can do that. It's an easy thing to do. And everybody thinks, oh, do I have to wear a weighted vest? Do I have to run? No, walking is totally okay to do. Of course, strengthening exercises are helpful as well. And there have been several studies suggesting yoga and Pilates can be helpful, especially the spine, which isn't as sensitive to exercise as the hip is. Tai Chi has also been shown in several studies to help prevent falls because of balance as well. People, if you smoke, you need to stop smoking, and alcohol intake needs to be moderate. A glass of wine a day is fine. You know, social drinking is not an issue at all. The other question that often comes up is, what about soda? Soda's fine, you know, in moderation, everything in moderation. If you're drinking too many sodas and not drinking milk, that's not great. And really there's phosphorus in soda and some patients worry about that. If your kidney function's fine, not a big deal. Caffeine, another concern that comes up. 2-3 cups of coffee a day, no big deal. If you're drinking 4 cups of coffee a day, it makes you pee out a little more calcium, about 100 milligrams per day, but you can balance that out with supplements as well. So I don't have a problem with coffee or tea. So I'm not going to go into all these clinical trials, but I want to emphasize the importance of what you're taking and how these medications are studied, because again, well, the health food guys said to take this. Well, what studies do they have? What were they looking at to give you that information? I'd rather take this than other medications. So this was just a study that was done years ago, looking at alendronate, one of the earliest medications we had to treat osteoporosis. The initial clinical trial was 3 years, and they looked at fracture reduction because we want to know, is this good bone or not? They looked at bone density improvements, and they did bone biopsies in a small percentage of patients to make sure this is normal bone. We have learned with osteoporosis medications, 3 years is not enough. We need to look longer than that, because with alendronate in particular, in the initial trial lowered the risk of fractures by 50%. But as you went out further with that medication, there started being reports of fractures occurring after 5 or more years. So, and we'll look a little bit of that data to understand that, but that's what's very important. How were these supplements studied? They weren't. How were the osteoporosis medications? And I'll go over each one to tell you a little bit about each study so you know that these are well studied and around. Very busy slide, we're not going to go through all of this, but how this whole 5-year limitation only on bisphosphonates, Fosamax, Boniva, Actinol, so alendronate, abandronate, risedronate, that's where the 5 years is. It's not with other medications, which we'll talk about. But you can see here, this is a group where it was stopped at 5 years. The bone density stayed very stable after discontinuation because it stays in the bone a long time, 10 years. Same with the hip, fairly stable, a little bit of a decrease after a couple of years, but there was no difference in the fracture risk from those who stopped at 5 years or continued for 10, unless this was a very high risk patient with very low bone density and multiple fractures. So for most patients, stopping at 5 years is very reasonable. Then the question that comes up all the time is the concern about the jaw. Well, my dentist says I shouldn't take these medications. So let's talk about that a little bit. Osteocloses the jaw is, the definition is exposed bone. I'll show you a picture of it. I think I have it next. Exposed bone for longer than 6 weeks. It is not jaw pain. It is not TMJ. Many times I've had patients say, well, I took these medications and I hurt my jaw, my TMJ got worse. TMJ is arthritis. It has nothing to do with this. And there's other risk factors involved with this: cancer diagnosis, other treatment such as chemotherapy, radiation, steroids, bad teeth, smoking. All of these make a difference. And putting this in perspective, one of the medications we use for treatment of osteoporosis is a medication called zoledronic acid, or Reclass. And we give at the most 5 milligrams per year. Cancer patients are giving 4 milligrams a month to prevent cancer from going into the bone. In those doses with chemo and radiation, if a tooth is pulled, about 1 in 5,000, it will slow the process. In the studies with zoledronic acid, which I'll show you later, it's not seen. And I have never seen jaw issues, osteocrosis of the jaw, in patients on osteoporosis doses. I have seen it in cancer patients, but not in osteoporosis. And in our group, we had an oral surgeon from University of Alabama, Birmingham speak a few weeks ago. Everyone in our group, that many of them have been treating, probably not as long as I have, but for a long time, haven't seen it. So it's not a common finding at all. The risk of osteocrosis of the jaw in a patient on osteoporosis medications is at the most 1 in 50,000, more like 1 in 100. The lifetime risk of an osteoporotic fracture, 1 in 2. Risk versus benefit here. That's what we have to look at. So Reclass is one of the medications, zoledronic acid, that we use very commonly in my clinic. It is an IV medication given once a year. The initial clinical trial was 6 years. They then took patients, about half of those patients, out to 9 years. Again, well-studied medication, bone biopsies were done, shown to be very safe. I'm not going to go through every one of these trials, but just important, in the initial clinical trial, they found at 3 years, 1 osteocrosis of the jaw in each group, whether placebo versus treatment. In the rest of the clinical trials, it was not seen. There was a recent study published last year out of Japan that it was a dental clinic where they had osteoporotic patients. Half of them were given Reclass and seeing their dentist regularly, which is very important for dental health, obviously. Half were just seeing a dentist regularly. Again, very important. What they found were those who were taking zoledronic acid, Reclass, had better dental outcomes, because if you're losing bone in your spine and hip, you're losing it in your jaw as well. And many times I'll have patients say, well, I spent all this money on these implants, I don't want to lose them. Well, you're going to lose them if you start losing all the bone in your jaws. So that's very important to understand. And underlying gum disease, which is very common, also is not a concern with these medications. Denosumab, or Prolea, in the initial clinical trial, it was 3 years where they had patients taking placebo versus those on denosumab, Prolea. There was no cases seen. In the 10-year trial, so this was a 10-year clinical trial, there were 11 cases reported from 4,000 patients. 7 of 8 of them had oral procedures. The one that did not had dentures, and poor fitting dentures is a risk as well. They all stayed on the medication and healed. And it's very important, if your dentist tells you not to take, especially denosumab, that you still keep taking it, because there's been reports of a rebound effect when it has stopped. So you got to stay on these medications. We'll talk about that a little more later too. Femur fractures have also been reported, and that's where this whole idea of drug holidays and limitations occurred. These femur fractures started showing up published in 2005. I saw my first one in 2003 on a very good friend's mother who had been on alendronate by then about 8 years and had a fracture from a fall that didn't heal. There's classic x-ray findings, which I'll show you. Oftentimes there's a prodrome of kind of an achiness in the thigh. So anytime a patient comes in and they've been on these medications and they're feeling pain, we will do an x-ray, because we can see a stress reaction, especially early on. This is what they look like. This is a patient that actually was a teacher, and this happened spontaneously in the classroom. She was brought to the emergency room, and anytime you have one fracture like this, we always want to look at the other side. And while this is very subtle, there's a stress reaction here as well. And she was symptomatic. She was having achiness on both sides. And it is recommended, when she had this one done and fixed, that we also prophylactically pin the other side, because the risk is so high of having another fracture. So what does this mean? They looked at this is with bisphosphonates, and that's where it's been seen. They looked at the long-term alendronate trial, the long-term Reclass trial and found 12 fractures that were what we call that met this criteria. Oh, sure. I thought I had another slide in there. And all of them occurred after 5 years of treatment. We are now finding that there are the risk factors that increase the risk of having one of these fractures. There's a new phenomenon that's pretty much been described at WashU called adult hypophosphatasia. There's a pediatric disease where the fractures look just like this. And there's blood tests that we do. We look at something called an alkaline phosphatase and a phosphorus level. So we screen for these things. And if I get to 5 years with a patient with alendronate in particular, we'll think about doing a holiday, or if they need to stay on something, we'll change to a different mechanism of treatment. Moving on from the bisphosphonates, raloxifene or Avista is a selective estrogen receptor modulator. It's not estrogen, but the bone thinks that's what it's seeing. And so it acts like estrogen in the bone. It lowers lipids. It is an anti-estrogen on the uterus and on the breast. So in the study, it was found to lower the risk of fractures in patients who haven't fractured by 55%, patients who had fractured by 30%. So this is more for preventing the first fracture from happening. It works very well in the spine. This is a younger patient population. There weren't enough hip fractures to show significance. So if I've got a patient who's osteoporotic in the hip, this would not be the medication that I would use. The anti-estrogen effect is important. This is the 4-year trial. They actually took it out to 8 years and found a 68% reduction of invasive breast cancer. So it's approved in the United States for treatment and prevention of osteoporosis, but also prevention of breast cancer. Side effects with this medication, most commonly is hot flashes. And because it lowered lipids, they did a study looking at women with heart disease. It did not show any benefit. And patients who had a high risk of heart disease, there's a higher incidence of stroke. So in patients who are at risk for that, and I kind of use it kind of an age cutoff, when patients start getting over 70, it's something I'm going to stay away from. And usually those patients have more significant osteoporosis anyway. Moving on to Prolea or denosumab. Prolea is not a new medication. It's been on the market now close to 14 years for treatment of osteoporosis. Little science here. How does it work? There's a protein called rank ligand. This is rank right here. It binds to the osteoclasts, the bone building, the bone breakdown cells. I always say the demolition crew, and makes them work faster. What Prolea is an antibody to that protein. So it goes directly to the cause of bone loss, eliminates it. It's done its job. Within a month, it's out of the body. Body starts rebuilding that protein again. It takes about 6 months to do that. So that's why it's a shot every 6 months. 10-year clinical trial, 8,000 patients were studied, lowered the risk of fractures by 70%. There's really no side effects different from placebo in the clinical trial. The FDA confuses everything by saying if it happened more than 5%, even if it's the same as placebo, it's a possible side effect. So for example, average age in the clinical trial was 70. I'm 60 and I have achiness and joint pain at times, but at 70, you expect that. 37% of patients at the start of the trial who received Prolea reported joint pain at the start of the trial. 37% of patients who were on the placebo reported that. No one's pain worsened while they're on it. But of course, when patients look at the information sheet, they're like, wait a minute, I already have joint pain. I don't want it to get worse. It doesn't get worse. Rarely do I have to stop this medication because of side effects. There's unexpected reactions. Patients react differently. I certainly will listen to their concerns as well. Another one that patients will say is, well, it increases your cholesterol. No, it doesn't. 11% of patients who were on Palia had a high cholesterol. 11% in the placebo group, they did not go up on this medication. I've even had physicians say, well, I can't put her on this because it raises cholesterol. No, it doesn't. So very safe and effective medication. What I always say is the good news about Prolea, denosumab, is that it's out of the body very quickly. The bad news is it's out of the body very quickly. And there have been reports of patients who miss a dose by more than 6 to 8 weeks of bone density going down very rapidly, and published reports of patients who have actually had multiple fractures, even if they haven't gone down to where their bone density was before. So the important thing about Prolea is you need to stay on that 6-month regimen. The other question that always comes up is, so am I on this forever? Well, until something better comes. This does not accumulate in the bone the same way as alendronate does, for example. It slows down the bone breakdown. That's how it works. And then in between, because it's kind of out of the system and this protein starts building back up again, there's normal repair in between. So again, very safe medication. We used to say 10 years was how long patients could be on it because that's what we studied. It's now been on the market for 14 years, and I have patients still on it. One of the good things about the pandemic, one of the few good things, is Zoom and meetings like this, because it's so much easier to get people together. Every Friday at WashU, we have a clinical conference where we present cases. And at the beginning of the year, when we have the new interns and residents, we go through treatment. And at one of the when we were talking about Prolea, one of the primary research for this is a guy named Henry Bone, who does bone research. And he said, when somebody asked how long to be on it, he said, it's one of the safest medications we have. And until there's something better, stay on it. We can transition off of it, and we have ways to do that using either the oral medications or Reclass. So I have some patients that actually improve on, they get so much better that we do transition over. Now we're going to move on to other medications that work differently. These are called anabolic medications. So everything we talked about so far stops the demolition crew from breaking down bone to allow the body to naturally rebuild again. Now we're going to be looking at what we call anabolics, bone buildings. One of the first ones approved for treatment of osteoporosis was a medication called Teriparatide or Forteo. It's a daily shot you give yourself, which I always have patients say, oh, I can't do that. It's not, it's actually pretty easy to do. And I always tell patients, if we talk about this, if you start it and you hate it, we stop it. Because what did I say earlier? This is about quality of life. It works differently. What the anti-resorptives do is put more bricks in the building. In fracturing patients, we know, here's a bone biopsy, we don't have the girders to support it. What the anabolics can do is rebuild that bone. And so this is a bone biopsy seen in these patients. So it mineralizes, but it also rebuilds the infrastructure of bone as well. Well-tolerated medication, very short time in the body. It used to have what we call a black box warning. So when Forteo was initially approved, when they were doing studies on humans, they were also doing studies on rats. The rats they were giving it to developed sarcoma as a type of bone cancer at a very high rate, not a medication. Then they took these rats and gave them 3 to 60 times the dose you'd give to an adult human. There was a slightly higher percentage of cancers in the rats on the medication than off. Human trials were stopped at 2 years. They also did a 4-year trial. Those patients have been followed for 20 years. No cancers have been seen. So this time limit has been taken away. We are still cautious in patients who would have a higher baseline risk of sarcoma, patients with a history of Paget's disease, a bone disease more commonly seen in men, or prior radiation therapy, because there have been rare reports of sarcomas, like, for example, in breast cancer patients who've had radiation. And in rats never close their growth plates. That's where rats get their cancers. So if I have a young patient who has not achieved full growth and their growth plates are still open, we're not going to use this medication. So again, this black box warning has been taken away. Another anabolic agent that we have for treatment is a newer medication. It's been on the market almost 3 years now for treatment. It's called Evenity. It is it's a very interesting approach. How it works, and this is kind of a schematic. Here's that demolition, the osteoclast, the demolition crew. It secretes a protein called sclerostin, which inhibits the bone builders. So when we block sclerostin, so it's a gate closer for the bone building cells. When we open that gate up, the bone building cells start building new bone and also remodeling and producing better bone in the future. So this works in 2 ways. It encourages bone formation. It also stops bone breakdown. So it kind of does everything we want it to do. That effect lasts for about 8 or 9 months. So this is a 1-year treatment. For more severe patients, it is 2 shots a month on the same day, just because of volume, for a year. In the studies with Evenity or romosozumab, the generic name, it was compared to placebo. It was compared to alendronate. It was compared to teriparatide, Forteo. What you see here is at a year, very significant improvements in bone density. We were part of this clinical trial, and while we were blinded, we didn't know what patients were taking. It was very obvious something different was going on with this medication. Same thing in the hip and the femoral neck, even compared to teriparatide, a very effective medication in bone building, especially at the spine, not as much at the hip. It is well-tolerated medication. Same thing as with denosumab. There was really no side effects different from placebo, but the FDA, again, if it happened more than 5%, headaches were reported at 8% in both groups, did not worsen while patients were on it. Joint pain, again, I think in every osteoporotic study, you're going to see joint pain and arthritis as part of the treatment, as part of the side effects, which doesn't make things worse. So effective medication and some practical stuff. These medications are expensive. Like romosozumab, denosumab, so Prolea, Evenity, and Reclass, Medicare B with a supplement completely covers. So that's a benefit for these medications, because sometimes I'll be asked, how do you pick Evenity over, teriparatide? Sometimes it's what we can get covered, because these are all very expensive. I have a patient who takes teriparatide, and until she gets through the donut hole, she's paying $1,200 a month, which takes a couple months, and then it's paid for. But these others are completely covered, and no issue with donut hole involved with that. So just to summarize the questions that have come up from the American Association of Clinical Endocrinology, and these have recently been updated. I need to change this slide, but very similar. So with the oral bisphosphonates, alendronate, abandronate, risedronate, the recommendation is after 5 years, if those patients who are moderate risk, it should be stopped. After 6 to 10 years in higher risk patients, and an important point to be made here is that it says years of stability. In these clinical trials, as long as bone density isn't going down, you're getting clinical benefit from these medications. Always nice when they go up, but some years we don't see a big improvement. It's still okay. For zoledronic acid, Reclass, in the clinical trial, they had patients who took it for 3 years and then were changed to every other year. And they found the same fracture benefit for those moderate risk patients by spacing the dosing out. And after 6 doses in higher risk patients. And so after that, we definitely start spacing dosing out more. And because Reclass is in the bone longer, there's fracture protection for sometimes 2 or 3 years in between each dose. You do not do a drug holiday in patients with denosumab because of this rebound effect. When do you go back on medications? Some people think, well, I've had 5 years, I can't go back on. You can. It depends on the situation. But if bone density starts going down, that tells me that the bone is becoming more active again and not quiescent from accumulating medication. So we can use these again. And it's individually decided by each patient. So I think that is a summary. Yeah, bad disease with significant consequences, which I saw so much of early on in my career doing this. It's much more gratifying now to not see so many fractures. We have multiple very safe medications that were well studied to treat osteoporosis, and understanding the safety, the risk and benefit of all these medications is important. Bone density is the best predictor of fractures that we have. And if you haven't had a bone density, the recommendation for when patients should get them, all women over the age of 65, men over 70, postmenopausal women with other risk factors, which I think every postmenopausal woman has other risk factors for screening. And so that's important. And then calcium and vitamin D are part of all these treatment regimens. Those are very important, and vitamin D levels should be measured, and look at these medications carefully because they're all very safe. And as I say, you got to talk to your physician about any concerns that you have. So I will stop here. And I think we have time for questions. I saw the chat. There's a couple things. Oh, okay. Right. That one I'll answer individually. So any questions that you have?
Susan Keller, go ahead. You can unmute yourself.
I was advised, pardon me, to take Reclass, to do that for 2 years. Is 2 years insufficient then? Or you're saying 3 years?
It depends on every patient. Well, if the osteoporotic, we usually say 3 years, but I've had some patients improve so much, they get out of the osteoporosis range, and then we'll start doing it every other year. So I don't think there's a one size fits all for patients. I think but it's very safe to do 3 years if that's what you need to do.
Dr. Deemer,
Yes.
Linda Kussmer.
Oh, hi, Linda.
So good to see you.
Yeah, good to see you.
I haven't been to you for several years, and I've gone through a lot of health issues since then. I've had a bone density because I have breast cancer. But should I be coming back to you, because what you have said about your testing and all of that, should I be coming back to you now to just kind of review everything and
Yep.
test? And
Yep.
how hard is it to get to?
It's kind of hard to get in. I'm cutting back a little bit on my clinical responsibilities because I'm getting older.
Yeah, I get that.
If you call the office, especially if you're a previous patient, they can find a space to do
Okay.
that. My nurse practitioner is wonderful as well.
I would like to see you though.
I know, I understand, but yeah, just give them a call. There's a question in the chat about estrogen as a treatment for women over the age of 65. And Bob, I'm surprised you didn't call me on that one. But so estrogen it does not have the long-term clinical studies when it comes to fracture reduction. So, but it's very effective. And in early menopausal women, it's very safe. I take estrogen. I'll tell you that right now. But it doesn't have all the data that we have for everything else. What I will tell patients is, if you're not symptomatic, and we're just taking care of your bones, we have other things that we can use. An important thing to understand, however, especially women over the age of 65, is in the Women's Health Initiative, which was that long-term study done years ago with estrogen. They had women taking estrogen and women taking estrogen and progesterone and looking at the outcomes long-term. In women who started on estrogen right at menopause or within 5 years, the risk of cardiovascular disease did not increase in those patients. It's women who were off of these medications for 5 years or more and restarted on them. So if I will tell women, if they're 10 years out from menopause, probably estrogen is not the right way to go. But earlier than that, 5 years or less, especially with symptoms, it's very important. And I kind of jokingly say, your body's telling you need it, but I know my body needs it. So I think that's important. So let's see. Oh, so some tips on positioning. The pictures all look the same. I'll just say, this was the hip nice and straight. The other one was out like this. And so I know it sounds subtle, but we see this all the time. In that positioning, one time we did my hip just to show the text, barely rotated it. 2 minutes time, 8% decrease. So it is very important to have these done correctly. So I'll answer another one on the that Marlita put in. Does Prolea have immune suppression effect? No, it does not. Theoretically, there are rank receptors on T and B cells. So there was a concern that maybe it could have immune suppression. That was not seen in the 10-year clinical trial. And put in this perspective as well, we give 60 milligrams twice a year for osteoporosis. Cancer patients receive 120 milligrams a month, plus chemotherapy, plus radiation. They're already at infection risk. With this medication, they did not see this. We use Prolea often, especially in kidney transplant patients, because it's very safe for the kidneys, and they're immunosuppressed, and we don't see a higher risk. So that was a theoretic concern that was never, ever a real concern, and no effects from COVID with this. And then a question is Reclass safe for women who have had breast cancer? Yes, it is. In fact, there was a study that came out a few years ago that showed that giving Reclass to breast cancer survivors not only prevent it from going into the bone, which is what we usually use it for, but actually prevent it recurrence. So oftentimes the oncologist will, when we're making decisions on treatment, will suggest using Reclass because it has been shown to be protective. That's usually a twice a year dosing. I work with the oncologist that they decide they want that done. So another question, I want to make sure if anybody has anything that they want to ask in person, Susan, I assume you're keeping an eye on that. Another question is I have osteopenia. I'm taking a Bandronate once a month. So a Bandronate, it is a bisphosphonate, so same family as a Lendronate. Their clinical trial was a 7-year trial. They chose patients in their study by spine bone density, not by hip. So a lot of their patients that were recruited did not have osteoporosis in their hip. So the initial study did not show hip fracture benefit. When they looked at those who were osteoporotic, they saw it. So I think it's another safe medication to use. Doesn't seem to stay in the bone as long as a Lendronate does. And when we do a drug holiday with either a Bandronate or Risedronate, sometimes in that year, bone density goes down. No higher risk of fractures during that time, but it's just a little bit different in how they interact with bone. So do you recommend a woman who's osteoporosis based on bone density tests seek help from a specialist? You know, a lot of primary care doctors are very good at doing this. You know, because this is all I do, I think I know, hopefully I know everything that you need to know about this, but many primary care doctors can take care of this and are comfortable doing it. A lot of OBGYNs will treat this as well. So I think it depends on you and your primary care doctor of how comfortable you feel. You know, our clinic, as I say, I'm pretty busy. We have cancellations. We have a cancellation list. Yesterday, I saw 3 people that we called the morning of and brought them in. But we have other people in our group, the bone health program, that are excellent. Most of them trained under me, and or Roberto Civitelli, the head of our division, we train together. So there's a lot of experience and help out there. And there's also at St. Luke's, there's a Bicolek, Dr. Bicolek out there who's very good as well. So I think it depends on your interaction with your primary care doctor, what they're comfortable with. If things aren't improving or things are going down, that's probably a time to see us. And the one thing I think is really important, again, is who's doing the bone density and how well are they doing it. Other questions?
Adrian, I believe, has her hand up. You can unmute yourself.
Can you hear me now?
Yep.
There's never much talk about men having osteoporosis. It's almost always aimed at women. And I noticed the commercials, the commercials for Prolea. It's always a woman on a ladder or a woman giving a bath to a dog or doing some other thing that's dangerous. And they always have a look on their face like they didn't know better. Why is it done like that? Why is it always geared towards women when men do have it also?
Right. You're absolutely right. The majority of patients with osteoporosis are women. And part of that's because at menopause, we have 2 different types of bone loss. One is menopause related estrogen deficiency, especially the spine goes down more quickly. So women have a more rapid earlier bone loss, but men also do gradually decrease, what we call age related. And we should be, that's why the recommendation is to start screening men at 70, because they do have fractures and they don't do well with fractures at all. All the clinical trials, the long-term clinical trials are done on women, but there are equivalency studies done in men on Reclass, on Prolea. Eventually, they don't have male studies yet. So it's not approved for men for that reason. But it's all marketing is what it is, because that's women probably talk about it more. But, and what's a shame is oftentimes when I first see a male patient, it's because they've had a fracture, because we don't screen for that. And they actually have shown bone density screening to look for fracture risk actually has better, outcome or yield than measuring cholesterol, looking for heart disease. So, and it's not an expensive test. I think Medicare pays us $45 for it, which is, it costs more than that to do it, but that's what Medicare charges for it. So it's something that I wish we could do men earlier. And usually, like I say, I can usually find a risk factor in a man as well. So I think men should be screened much more frequently than we are doing right now. Definitely.
So there are a couple questions in the chat. Linda asked, do you recommend that any woman who has osteoporosis based on a bone density test seek help from a specialist?
Yeah, we talked about that a little bit. I think that depends on who your primary care doctor is, your OB/GYN who's taking care of you, their comfort level with treatment. Certainly, if things aren't going as expected, then it's time to see a specialist. And then Susan asked, with Reclass after 2 to 3 year regimen, is it then necessary to start up again after drug holiday? It's again, it usually after 3 years, if we're in the osteopenic range, we measure bone density. And then when bone density goes down, that's when we make the decision to go back on treatment again. As I say, I have some patients. I saw a lady yesterday that went almost 5 years between doses. Very safe medication, but why take any more medication than we have to? But it's important to be having these bone densities done at a site that can really see a change and know that it's real. And the drug holiday, again, how long does it last? It depends on what's going on with your bones.
Should strengthening exercises always be a part of the equation, asks Mary.
Yeah, exercise is always a very important part of treatment of osteoporosis. As I say, I think the walking is a great thing to do. That really helps the hips. Core strengthening exercises are also very good. Balance exercises are great. And there are a lot of like the Silver Sneakers program. St. Luke's has a program for osteoporosis exercises as well. I think all of those have a role and part of this. Sometimes I have a patient who's been really stable. This happened a lot of the pandemic where, and their bone density went down. Well, what was different this year? Well, I wasn't exercising as much. And some will say, because they're not in the osteoporosis range yet, give me a year. I'll get back on exercise again. And sometimes that's all we need to do. Not always. But the one thing I say is exercise, calcium slows bone loss. It does not stop it. Because I have patients who really low bone densities who think exercise and go to some of these places around the city that say that you can do this instead of treatment. Those have not been studied well enough. And again, and I also have with a new patient who's osteoporotic, but I did everything. I took calcium, I exercised. I always say, if you hadn't done that, you would have been worse. So what you've done is make the best of what you could do. But that's why we have all these medications, because that alone doesn't work for too many people. So Sharon asked, how do you decide between Reclass versus Prolea? Some of it is the patient itself, how low their bone density is. Prolea probably improves bone density a little bit faster, but we are making a long-term commitment to that. I probably, for the most part, use Reclass first, because if patients respond, we can start spacing the dosing out. If patients had pain with an oral bisphosphonate, achiness, then I will not use Reclass, because I've learned my lesson before we had Prolea that, I felt achy when I took a Banderdate, and then we tried to give them a half dose of Reclass and they were really achy. So then I won't use it. Also with Reclass, if patients are in stage 4 kidney failure, so we measure something called a creatinine before we give it. If the creatinine clearance is below 35, I think the FDA says 30, I use 35, then it's not a medication that we will use. We then go to Prolea, which has been shown to be safe with creatinine clearances even into the 20s. So that can make a difference. And sometimes it's patient preference, or sometimes it's the insurance company. Again, Medicare B is great. We can choose what's best. Some of the other Medicare HMOs or plans will make you try an oral medication first and kind of go through the stepwise pattern to get to where we need to go. So some of it is, unfortunately, isn't my decision. Insurance companies are making those decisions for me, which drives me crazy. So Susan's asking, is the DEXA testing at the CAM building part of your program? There's 2 DEXA testing that's being done in CAM. One is on the 5th floor, which is our techs. It's a bone health program techs. And then Mallinckrodt Institute of Radiology does them as well. Depending on who their tech is, some do them very well, some do not. So I think, again, I'm biased. I will be very honest with you. I think our techs do a great job, but I think that's where to go.
If I could make a statement
Sure.
with that, I think it's very important to get your bone density at the same place every time, because going to one place one time and then a different, and then your internist, your OB, your the veterinarian for the dog, everybody wants to do a bone density, and you do not get good care by doing that. Be consistent.
Thank you, Dr. Becker. You're absolutely right. And we cross-calibrate our machines. So ours will give you the same result, either one, but we still try to stay on the same table when we can. And as I say, I'll have patients say, well, will you look at my last one that I had done somewhere else? And can you tell me? Can't tell you much, because if it's a different brand, completely different databases, different positioning. So it is important to have it done at a site and staying with that site.
Dr. Deemer, I have a question. You had talked about hormone replacement as being preventative for osteoporosis if you started in early menopause. Is there a limit to the amount of time you can be on hormone replacement? I mean, could you be in your late 80s and still taking hormones?
I see a lot of internists telling women after 5 years or whatever to stop it. I'm staying on it forever. I just think as I say, I think it depends on the patient, but I think it's an individual decision. I had a lady that I've taken care of for years who was having a workup done for something else, was shown to have on a head CT or head MRI, brain MRI, small vessel disease, so vascular concerns. With her, it was time to stop it. So some people will use a certain age, but I have some women in their 80s who are on it, and they won't stop it. So I think it's a risk benefit ratio that has to be decided between your internist, your bone doctor, your OBGYN, and everybody's going to have different opinions on this. And so it's got to be, and there's no right or wrong answer at all.
So Marilyn Alton has her virtual hand.
Hi, Dr. Deemer, Marilyn Alton. I'm
Hi,
a
Mary.
patient of yours. Remiss, I haven't seen you, but it's really a privilege to have you. But the one thing I've always felt, all of these things are so important, as you mentioned, and there was a doctor on Alzheimer's. But I'll never forget, my internist said, well, am I going to get this? My mom had osteoporosis. I got it. His answer to me was, he laughed, choose your parents. It's hard to beat the genes. And what do you think about that?
That's true. 70% of your bone density or your bone strength is genetics. It can be mom or dad's side. And there's different patterns. Sometimes we'll see the spine looks normal, the hip is low, or vice versa. And usually, I saw a younger man who has had several fractures. He's very active with their bike and stuff, but his bone density when he came in, he was in his 50s, was -4.
Ooh.
That's really low. And so we're going to make sure we're going to look at every reason for why that would be so low. But we also had his parents weren't alive, but his brother came in and had a bone density -4. So there's definitely a genetic pattern involved with this. But that doesn't mean we can't treat. And so many of my patients will say, I don't want to go through what my grandma went through or what my mother went through. Because back when, my mom's 99 and, we didn't have that good a treatment back then. And now we do. So just because your parents went through this doesn't mean you're going to, because we have very effective medications that can prevent that from happening.
Well, I am mindful of the time, and I just want to thank you so much there is actually one final question.
Yep.
I think if you want to answer that,
Sure.
but let this be the last.
Okay, sure. Yeah. So the question is, when scheduling a scan, should the patient ask about the expertise of the technician? Yes. And what you could ask for is, are they ISCD certified? International Society of Clinical Densitometry certification, which is a course that I teach that the technicians take. Physicians can take it as well. It's a little different course for physicians or nurses. And that, I think, tells you that you've got a good scan. There are some very good techs out there that have not had ISCD testing, but you should ask, do you do precision studies? And there's different types of precision studies. Every morning we have what we call a phantom, which is it looks like bone that we put through the scanner to make sure it's a stable reading, because sometimes a tube can go out and that could change things. That's not precision testing. That is just making sure that the machine is accurate. Precision testing is the positioning where the patients are on and off the machine. Yes, I believe that's very important to ask that question. Problem is, you're going to hear no from almost everyone.
Well, thank you, Dr. Deemer. Today's presentation was fantastic, so informative, and it has been recorded. So anyone here you can review this material again, because I know we covered a lot. And Dr. Deemer, you are fabulous. I know why they call you the osteoporosis guru. You're the best. So thank you again. Thank you everyone for being here, and have a good rest of the day.
Thank you.
Thank you. That's my girl, Kathy.
I know.